All right. Well, Fireside Chat, it actually was a beautiful day, and I thought, what better place to be by a fire tonight? But we're actually indoors. But nonetheless, we can pretend we're sitting out by the fire enjoying that today. So as Paula mentioned, thank you all for being here. It is nice to see some familiar faces, and hopefully this program will grow over the years to come so that we can reach out to more people in the community. For those of you who don't know me, my name is Dr. Jessica Nairn, and I'm a locum family physician actually practicing in South Muskoka, both in the community and at the hospital. Today I've selected a topic that is a common medical condition. And it's called COPD, or chronic obstructive pulmonary disease. This is something I see in both settings, both in the hospital setting as well as in my community practice. So by way of introduction, some of you may wish to know a little bit about my background. I'm not a lung specialist, unfortunately. I was born and raised in Huntsville before leaving for my undergraduate training in kinesiology at Wilfrid Laurier University in Waterloo, followed by my medical school training in Northern Ontario School of Medicine. I traveled all over the north, but actually spent a good chunk of my time in Thunder Bay. I actually got the opportunity to come back to Muskoka for my third year of medical school, and actually Paula mentioned as well that there are medical learners in this community all the time, which we're so grateful for, because we hope to actually get them to come back and stay here and work here and hopefully care for all of you and me. So it's been a pleasure to get the opportunity to come back home. I was taught in my third year by many of my respected colleagues in Huntsville, and 2 years later I was granted the privilege to return home to complete my residency training in rural family medicine, and being mentored by some of my Bracebridge colleagues here. It was the greatest mentorship I've probably ever had in my life, and I've never left this community. My husband and I feel pretty blessed to get to live here, play here, and raise our two little girls here in this place we'll forever call home. All right, so moving on to the more important stuff for this evening. I have some learning objectives. Bear with me, it's a lot of content, some of it's a bit dry, and I'm hoping you'll get something out of it. And we'll have an opportunity at the end for some questions and answers, hopefully some answers, to meet your learning needs as well. I'm going to talk a little bit at the beginning of this presentation about the anatomy of the respiratory system and the lungs. Next, go through what COPD is and what causes it, recognizing the signs and symptoms of COPD, appreciating the differences actually between COPD and asthma, because there can be some confusion there, and learn about how COPD is diagnosed. We'll also go through some of the treatment approaches and then discuss some local resources available to support patients with COPD. I have a few disclosures this evening. As I mentioned, I'm not a lung specialist, but rather a family physician. So there are some questions I may not be able to answer, and I lean on my colleagues to help me in those tricky situations, but I'll do my best today to answer any questions you may have. The second is, I have no affiliation with any drug companies, so if you see names of medicines on the slides, I'm not advocating for them over anything else. It just happened to be the picture I found, so bear with me, but I'm not holding out cards for any certain company out there. And finally, I do actually have a bit of an invested interest in our cottage country family health team, and I will advocate for the use of some of their programs during this presentation tonight. All right. So before we chat about COPD, I thought it actually most helpful to talk about the anatomy of the lungs and the role of the respiratory system. We take nearly 25,000 breaths a day thanks to our respiratory system. The upper respiratory tract starts at your nose. Your nasal cavity or nose is how most outside air enters your respiratory system. Your nose connects directly to your sinuses, which help to regulate the temperature and humidity of the air we breathe in. And air can also enter through your mouth, especially if you have a mouth breathing habit or if your nasal passages are blocked temporarily for some reason. The throat or pharynx collects that incoming air from your nose and your mouth and passes it downwards towards your trachea, also known as your windpipe. This is the beginning of the lower respiratory tract. The trachea, or the windpipe, leads from your throat to the lungs. Everything from the trachea down makes up what we call the lower respiratory tract. The trachea divides into two main bronchi, fancy name for tubes, and there are two tubes. Each lung has its own designated tube or bronchi. The bronchi in turn then subdivide into even smaller tubes. These are called bronchioles. And your lungs are located on either side of your sternum or the breastbone in your chest. Your lungs are divided then into 5 main sections. We call these lobes. If you've ever had pneumonia, your doctor may have said, oh, you have a middle lobe pneumonia. That's what they're talking about, is the lobes. In fact, the right lung has 3 lobes and the left lung only has 2. Little fun fact for trivia night. And the heart is nestled between your lungs. The heart and the lungs are protected by your rib cage. At the end of the bronchioles are the alveoli. If I lose you here, that's okay. I did a trial run of this presentation with my husband, and he said, yeah, that went right over my head, so you're not alone. Some of this may come back to high school, science class, I'm not sure, but hopefully we can help you through it. So I like to think of the alveoli, those are these little circles here, as bunches of grapes, all attached to the bronchioles or the stems. Embedded in the alveoli are tiny capillaries. Capillaries is a fancy name for blood vessels where gas exchange takes place between your blood and the air that you breathe in. All of the cells in our body need oxygen to stay alive. And carbon dioxide is made in our bodies as the cells do their jobs, but this carbon dioxide is actually a waste product, so we need a way to breathe it out or get rid of it. So the lungs allow oxygen in the air to be taken into the body while also letting the body get rid of carbon dioxide in the air that we breathe out or exhale. I really liked this diagram. It kind of describes the diaphragm as an umbrella, so I'm going to use that analogy for a minute here. The diaphragm is located below the lungs, actually, and it's the major muscle of respiration. The diaphragm is a large, dome-shaped muscle that contracts rhythmically and continually, and in most instances, involuntarily. We don't control this contraction. When you breathe in, the diaphragm contracts and flattens like a squished umbrella, and then the diaphragm moves downwards towards the abdomen. The rib muscles pull the ribs upward and outward, and this makes the chest cavity bigger and pulls air through the nose and mouth into your lungs. When you exhale or breathe out, the diaphragm moves upward, the chest wall muscles relax, and this causes the chest cavity to get smaller and push air out of the respiratory system through your nose and your mouth. So every second, with each inhalation, air fills a large portion of millions of these alveoli, or our cluster of grapes. In a process called diffusion, carbon dioxide and oxygen are exchanged across tiny blood vessels, those are those capillaries, lining the alveolar walls, as you can see here by the yellow strip surrounding the alveoli. In the yellow line, you'll see blue and red circles. The blue circles represent the blood that is lacking oxygen as it passes through the lungs. The flowing blood drops off carbon dioxide to be exhaled, because it's the waste product. It then picks up oxygen with each inhalation. Once in the bloodstream, oxygen is carried by red blood cells back to the heart, where it pumps it through arteries to oxygen-hungry tissues throughout the body, like our muscles, or any cell for that matter. Your respiratory system also plays an important role in keeping your body healthy and free of bacteria, viruses, and other substances that cause illness. The respiratory system is in constant contact with your environment. Many different pathogens, or those things like viruses and bacteria, can enter your body through your respiratory system. The mucus layer that lines the upper respiratory tract helps trap those particles, and sneezing and coughing are 2 examples of how your body gets rid of them. Okay, now that we've addressed some of the normal anatomy and the function of the respiratory system, let's go through what can happen if these structures or processes get disrupted. Perhaps some of you tonight have never heard of COPD, and that's okay. That's why you're here, and I'm glad you are. Chronic obstructive pulmonary disease, or COPD, is a treatable, persistent, and progressive lung disease that causes airflow obstruction, or in other words, an obstacle for airflow, and thus gas exchange, or the alveoli. Obstacles make our life difficult, and COPD is certainly no different. COPD is an umbrella term that includes chronic bronchitis as well as emphysema. So if you've been told you have that diagnosis, that is also COPD. It is hallmarked by chronic respiratory symptoms such as shortness of breath, cough, sputum production. These symptoms are due to abnormalities of the airways and or the alveoli. Little fun facts, or not so fun. COPD affects more than 2 million Canadians, and it is one of the leading causes of hospitalization in our country. 26% of Canadians over 85 live with COPD, and globally, COPD is the third leading cause of death. There are estimates that up to 1 million more in Canada are living with COPD and don't know it. So why is COPD so underdiagnosed? A person may not have symptoms or assume their symptoms are related to age, a common respiratory infection, or even a smoker's cough. People who do not smoke any longer might think they can't develop COPD. Some people are diagnosed with asthma when really their symptoms are as a result of COPD and not asthma. People with COPD are often also living with other health conditions like heart disease, which they may assume is the cause for their COPD symptoms. An example of this would be shortness of breath. COPD is a combination, as I mentioned, of lung diseases that cause the airway in the lungs to become swollen and blocked. Shortness of breath and increased difficulty with everyday activities are two of the most common reasons or signs of COPD. Emphysema and chronic bronchitis are the two conditions that contribute to COPD in most cases. Bronchitis, as depicted at the top of this slide, occurs when the airways in your lungs, or your bronchi, become inflamed. This can cause severe coughing spells that brings up mucus, wheezing, chest pain, and shortness of breath. Bronchitis that doesn't go away is called chronic bronchitis. Emphysema, on the other hand, at the bottom of this slide, develops over time and involves the gradual damage of the lung tissue, specifically the destruction of those tiny little grapes, or the alveoli. Gradually, the damage causes the grapes to either rupture or coalesce and create one big air pocket instead of many small ones. This process, unfortunately, reduces the lung surface area that is required for effective gas exchange. The damaged tissues prevents oxygen from moving through the bloodstream, and over time the lungs overfill and retain CO2, or carbon dioxide, which makes breathing increasingly more difficult. Fatigue, breathlessness, and chronic cough is often the result. So who gets COPD? COPD results from genetic and environmental interactions occurring over the lifetime. These interactions can cause damage to the lungs and alter their normal development and aging process. The main environmental exposure leading to COPD is tobacco smoking and the inhalation of toxic particles and gases from household and outdoor air pollution. It is estimated that about 15 to 20% of those who smoke will eventually develop COPD. 1 out of 4 cases of COPD will occur in people who have never smoked. So it is possible to have it having not smoked. This 25% of cases usually have other associated risk factors, for example, exposure to occupational dusts and chemicals, exposure to biomass smoke, for example, burning coal, wood, or charcoal, or exposure to secondhand smoke. Certainly, the long-term exposure to air pollution is also lumped into this 25% of other causes for COPD. Frequent lung infections as a child, and I've shown a little sick kid here, and poorly managed childhood asthma are also associated with increased risk for COPD. Both environmental and host factors contribute to the development and the acceleration of lung aging. This is kind of a funny concept. But like a car that eventually runs out of steam or the parts start to wear and tear, our bodies do much the same. So lung aging is the aging of the organ itself, and it does take time to happen. But in these cases with little ones, the most worrisome thing is that with early infection or early insults to the lungs, we see an acceleration in the lung aging. In fact, some literature, recent literature, suggests that by the time the lung matures at the age of 25, if there have been early insults to the lungs, such as childhood infections, you may never be able to catch up and complete that lung growth. This accelerates the decline in lung function compared to a person who did not have those childhood infections and or early lung insults. Both environmental and host factors contribute to the development of this accelerated lung aging. The most relevant, albeit rare genetic risk factor for COPD is actually a condition called alpha-1 antitrypsin deficiency. If you have never heard of it and it doesn't run in your family, consider yourself lucky. It is quite rare, mind you. There are a number of other genetic variants that are also being associated with reduced lung function and the risk of COPD, but these are still under study and far less frequent or common as the alpha-1 antitrypsin deficiency. In the years to come, I anticipate that childhood history and recurrent infections, as well as environmental risk factors, become more apparent in our talk about COPD. There's suggestion that they may have an important role as a history of tobacco consumption in the development of risk of COPD. All right, what are the symptoms? I've mentioned many of them already, but we're going to go through a few more here tonight. COPD ultimately develops over time. It's not something that you'll get tomorrow and not have any indicators of it leading up to necessarily. In most cases, COPD is diagnosed in people over the age of 40. Someone with COPD may not even realize that they're becoming more short of breath until it becomes very hard to do the simple tasks like walking up a flight of stairs. People with COPD usually have one or more of the following symptoms, but as I mentioned, the underdiagnosis of this disease is because it can be caught earlier prior to having symptoms. So, a cough with mucus or sputum production may be an indicator that you could have COPD. A cough that lasts a long time, and a long time defined roughly as 3 months or more. Feeling short of breath, especially during physical activity. Respiratory infections that seem to last longer for you than for others, or an increased frequency of those infections, such as flu, acute bronchitis, or pneumonia. Wheezing is a common symptom. It's like a whistling sound when you breathe, or feeling tired, or even losing weight when you're not trying. In addition to these common symptoms, people with COPD are more likely to develop non-respiratory diseases. Examples of this would be cardiovascular disease or diseases of the heart and the circulation, diabetes, osteoporosis, anxiety and depression, sleep disorders, and even anemia. So you may be asking, am I at risk? Or maybe your loved ones? If you're over 40 and smoke or used to smoke, you may be at risk of COPD. Those are two simple questions. But it may be important to speak to your healthcare provider if you have other risk factors for COPD, even if you don't have symptoms or even if your symptoms are mild. COPD, as I mentioned, is a progressive disease, meaning it gets worse over time. Although there is no cure, COPD is treatable, and the earlier we treat it, or earlier we diagnose it, the more treatment options are available. The Canadian Lung Health Test can be used by anyone to assess their risk factors or risk for COPD. So I've got a few questions here for you. You don't have to answer them, just in your heads. If you answer yes to any of the following questions, I urge you to consider speaking to your doctor or nurse practitioner about lung function testing, also known as spirometry, and we will talk about that a little bit later. So question number 1, do you cough regularly? Question number 2, do you cough up phlegm or sputum regularly? Do even simple chores make you short of breath? Do you wheeze when you exert yourself or at nighttime? And finally, do you get frequent colds that persist longer than for those of other people you know? Take a deep breath. It might be time to talk to your doctor. or your nurse practitioner, but it'll be okay. And it's better to talk about it now than later. All right. Let's now briefly talk about asthma. Both COPD and asthma can cause a cough, shortness of breath, and wheezing. Some people who have asthma might be misdiagnosed with COPD and vice versa, and some people have both asthma and COPD together. So what are the differences between asthma and COPD? Here's a little chart to make it simpler. Hopefully you can read some of these. Asthma, as a general rule, tends to develop earlier in life, often in childhood, as I mentioned. The asthmatic cough is typically a dry cough without sputum or phlegm production. Asthmatics are often triggered by allergies, exercise, cold environments, and quite often there's a family history of asthma as well, which isn't necessarily the case in COPD. A patient with asthma may have days, weeks, and even months sometimes without symptoms if they avoid their triggers and take their medications as they've been prescribed. Whereas a patient with COPD has symptoms that are fairly consistent day to day, but gradually get worse over time. COPD exacerbations, on the other hand, are most often triggered by infection or air pollution, and these can come into play as well. Unlike an asthmatic, airflow obstruction is not fully reversible in COPD with the use of inhalers, and this is a key difference when we diagnose it with spirometry, and I'll talk about that in a little bit too. One important difference in COPD that I think has more long-term effects that are important is the result of prolonged poor oxygenation from long-term obstruction, which ultimately can lead to other chronic diseases, for example, heart disease or vascular disease. Poor oxygenation in an asthmatic patient, on the other hand, it's typically short-lived, such as in the setting of an asthma attack, and it doesn't seem to have that same consequential long-term effects on other systems or chronic disease. Not a complete truth there in that it can increase your risk, but it's not as clear-cut. All right, moving on. So what might make your healthcare provider consider a diagnosis of COPD? One thing I learned very early in my training was the importance of listening to my patient's history or concerns. That's what makes this really uncomfortable because I don't usually do this much talking. The patient's story typically provides clues to the diagnosis before I even attempt a physical exam in most cases. Thank goodness I'm not a vet because I'm pretty sure I would be the lost puppy in that situation. The Global Initiative for Chronic Obstructive Lung Disease, also known as GOLD, as you see here on this slide, is an organization that produces guidelines for healthcare providers. And we use these to diagnose and to find out treatment options for COPD. So this chart, it's more for my benefit than for yours, but it was taken directly from the GOLD guidelines, and it helps us pick up on those features that make us worry about whether or not you have COPD. So most patients with COPD describe their dyspnea, or also known as shortness of breath, as a sense of increased effort to breathe, chest heaviness, or air hunger or gasping. The shortness of breath tends to be with exercise and worse over time. I shouldn't say with exercise, worse with exercise, but also with exercise. Wheeze and chest tightness are symptoms that may vary between days, and the wheezing can be pretty easily heard when a doctor or nurse listens to your breath sounds. So that's a telltale sign in some cases. Chronic cough is often the first symptom of COPD and is frequently discounted by the patient as an expected consequence, perhaps of smoking or some environmental exposure. And initially, the cough may be intermittent, but subsequently it may become present every day, often throughout the day. So patients commonly raise small quantities of this tenacious sort of sputum with coughing. Regular production of sputum for 3 or more months in 2 consecutive years is the classical definition of chronic bronchitis as opposed to acute bronchitis that happens only for a short period of time. But this definition is somewhat arbitrary and does not reflect the entire range of sputum production that occurs with COPD. A big giveaway in the world of COPD diagnosing amongst primary care providers like myself is a frequency of lung infections. Second only perhaps to long-standing smoking history and other associated risk factors that we've already reviewed. But if you've come to see me time again and time again and time again with yet another lung infection, I'm probably thinking about COPD. If any of these clinical indicators are present, they are not diagnostic themselves. I might be thinking about it, but I can't make the diagnosis. Rather, they increase the probability of COPD, and we consider lung function testing or spirometry to make that formal diagnosis. In March of 2023, the World Health Organization, or WHO, released some key facts that I thought highlight well the severity of this condition and why screening is important. I've mentioned some of the risks in Canada. COPD is the third leading cause of death worldwide, causing 3.23 million deaths in 2019 alone. Nearly 90% of COPD deaths in those under 70 years of age occur in low and middle income class countries. COPD is the seventh leading cause of poor health worldwide, measured by disability-adjusted life years. And tobacco smoking accounts for 70% of COPD cases in high-income countries, like Canada. In low-middle income countries, smoking accounts for only 30 to 40% of COPD cases, and household air pollution is a major risk factor. COPD is the fourth leading killer of Canadians. It has a higher hospitalization rate and readmission rate than heart failure, angina, and other serious chronic diseases. Despite this disease process being a significant cause of illness and death, we are encouraged not to screen for it with special tests such as spirometry in all people across the board. Rather, our screening is based on effective history taking, so hearing the story, and risk factor analysis to identify those that are at greatest risk. For example, if you're asymptomatic, meaning you have no symptoms and you have no risk factors, no screening is required or even encouraged. But should you develop symptoms or be asymptomatic with risk factors, spirometry is indicated and lung function testing is indicated. So when diagnosing COPD, your healthcare provider will consider your age, your symptoms, your medical history, and the results of a physical exam. It's important that your provider orders lung function testing or spirometry to confirm that diagnosis. Spirometry is a simple breathing test that measures the speed and the amount of air you are able to blow out of your lungs using a device called a spirometer. Your results will be compared against a reference range or an expected value based on your age, your height, your sex, your race. This test, spirometry, is non-invasive, meaning not painful, not a lot of risk. It is reproducible. It's relatively inexpensive in the grand scheme of public health dollars and reasonably available. Locally, it's completed in our hospital, and on occasion, we have a visiting clinic in the community that can offer this type of test. Once the lung function test is completed, your healthcare provider will determine if COPD is the cause of your symptoms. If you don't meet the criteria, and the criteria here is listed as this funny ratio of FEV1 over FVC of less than 0.7, that's for my information, not yours, don't worry. An alternate explanation for your diagnosis for your symptoms has to be explored if you don't meet that criteria. You may be asked to use an inhaler or puffer during this test, and the more normal your results are after using an inhaler, the more likely that it is that you have asthma, which tends to be reversible with puffers. If the obstruction persists with the use of a puffer, it's more likely that you have COPD. Keep in mind there is a bit of crossover between the two in some cases. Sometimes it's prudent for your healthcare provider to rule out other health issues that may be causing your symptoms or may be underlying and yet not diagnosed. You can have COPD and other conditions at the same time, believe it or not. We call these other diagnoses comorbidities, and it's important that we consider hunting for them at times. For example, your doctor may order a CT scan or a chest x-ray, and these tests should not be used to diagnose COPD. That's what spirometry was for. If a CT scan or chest x-ray shows signs of possible COPD, spirometry should be used again to confirm that diagnosis. It is important to recognize that incidental lung abnormalities may be detected on a CT scan or an x-ray. Particularly in a non-smoking asymptomatic COPD patient for whom we sent for imaging studies for another reason, we often do pick up on these incidental findings. In these cases, findings such as lung fibrosis, inflammation, detection of emphysema, as well as air trapping and mucus plugging, these can all be seen. These findings may raise our suspicion for COPD, and your provider will probably come and tell you it's time to go for spirometry. For those with a 30-pack year history of smoking, it's reasonable for doctors and nurse practitioners to screen patients with what's called a low-dose CT scan and spirometry. In 2016, the Canadian Task Force on Preventative Health Care released a new guideline that recommends annual screening for up to 3 consecutive years, for lung cancer, only in high-risk adults aged 55 to 74 years old. And this is with that low-dose CT scan. So what's high risk in this setting? High risk is defined as a current or former smoker who quit within the past 15 years and who have at least a 30-pack year history of smoking. You're thinking, what on earth is a pack year? And you're not alone, because I asked that same question in medical school. It made no sense to me. So smoking is often measured in pack years, which is the average number of packs smoked daily and the number of years of smoking. For example, if an individual smokes 1 pack a day, that's approximately 20 to 25 cigarettes, for 30 years, they have a 30-pack year history. This buys them a CT scan to screen for lung cancer and potentially lung function testing to screen for COPD. This is true as well for the patient who smoked 2 packs a day for 15 years, or half a pack a day for 60 years. All of these examples have a 30-pack year history and a significant increased risk of lung disease, such as lung cancer or COPD. This is a very busy slide, and I apologize for that. If you are diagnosed with COPD, your doctor will also tell you the severity of your COPD, and that's why this slide is here, just to show you that there's mild, moderate, severe, and then very severe or end-stage COPD. When determining what medications are best for you, your provider will consider your symptoms, your spirometry results, your history of exacerbations, and any comorbidities that may be affecting your respiratory health. I'm not going to go into the detail of this chart today for the sake of time, but what I wish to impress upon you is that the very severe COPD is considered an end-stage disease. It highly affects your quality of life, and patients are often requiring supplementary oxygen when they hit this stage. You may also find yourself suffering from severe recurrent infections, which lead to frequent and prolonged stays in hospital. As primary care providers, this is what we're trying to prevent. We don't want to see you here. And we want to catch the diagnosis early and support you along the way so that you don't get there. What medications will I be prescribed? The big question. The medications that your healthcare provider prescribes you to treat your COPD will be based on your lung function, your symptoms, your health status, your risk of exacerbations as examples. But they will also consider how well you can use an inhaler. Inhalers come in many different forms. Using your inhaler improperly can mean you won't get the full dose of your medication. And asking your provider or your pharmacist or maybe even a respiratory educator or nurse to assess how you use your inhalers is really important to ensure proper technique. It's important that you take the right medication at the right time to best manage your COPD, just like other conditions. Over the last several decades, the advent of new inhalers has made the selection of devices seem at times overwhelming. So you see on this slide so many different options, and this too overwhelms your providers when we think about which one to use for you. Many healthcare providers probably have a preferred few inhalers, but as new products are made, we can optimize your treatment according to your specific needs and responses to medications that we try. We may also consider the affordability and drug coverage options in helping you make these decisions on which inhalers to try. Some inhalers, and I know this is hard to read, but I'll just try to describe. Some of them have only a single medication in it, while others can have up to 3 medications in one inhaler combined into one. So please keep in mind, more medicine in one doesn't always mean better. Each medicine has its own purpose in treatment and associated side effects as well as cost, which we as your providers carefully consider. So let's talk about some of these medications. One class used for the treatment of COPD is called bronchodilator. An inhaled bronchodilator relaxes the muscles around the airways, which helps to open the airways to help you breathe more easily. This medicine is delivered using, as I mentioned, one of these inhaler devices, also known as a puffer. And there are 2 types of bronchodilators that we consider controller medications. The first is a LABA, or long-acting beta-2 agonist, which works simply by relaxing the tightened muscles around your airways, lessening airflow obstruction. The second class, number 2 here, is the LAMA, or long-acting muscarinic antagonists, also called anticholinergics, which prevent, again, the muscles around your airways from tightening and help clear mucus from your lungs. This allows you to cough up mucus more easily. Bronchodilators are subsequently divided into long-acting and short-acting inhalers. So I've described here the long-acting ones, but there's actually short-acting ones as well. I like to think of these inhalers, the ones on the previous slide, LABA and LAMAs, as long-acting medications used daily that keep COPD under control and prevent bad outcomes. There are different styles of inhalers containing different types and amounts of the medications needed, and they are to be used in a very predictable pattern, daily, sometimes twice daily, around the same time each day. I think of the short-acting bronchodilators as your rescue inhaler, to be used not for prevention, but when you are really struggling to breathe, when you feel air hunger. They work quickly to relax your airways, which gives you some immediate relief from your symptoms, but these medications wear off in a few hours, so they're not as useful for the prevention of badness down the road. So the second class of medications we use for treatment of COPD is something called an inhaled corticosteroid. Again, it's an inhaler or a puffer. It's a separate class prescribed to decrease inflammation and swelling, as well as mucus production inside the airways. Inhaled corticosteroids are not used alone to treat COPD, but they may be prescribed as an add-on to the bronchodilator therapy, those LABAs and LAMAs we just spoke of. This diagram here shows us what happens to the swollen and narrowed airways after we make use of 3 different types of medicine. You can imagine that if we only use steroids, your airways would remain obstructed by the smooth muscle contraction. The LABA and LAMAs are thus essential to navigate the airway obstacle course. You can see that on the second half closest to me here, the smooth muscle contraction that is released with the LABAs and the LAMAs. All right. What is a flare-up? Also known as an exacerbation. These occur when your COPD symptoms quickly become worse and stay worse for a few days at least. Respiratory infections and air pollution are the two most common triggers of COPD exacerbations. What are some of the common signs of a COPD exacerbation? More coughing than usual, coughing up more phlegm or sputum, and sputum that's often a different color. You might be more breathless or wheezing, and you may find yourself fatigued. Some people may even require more oxygen than they usually do, and that can be provided supplementarily. So what do you do if you have a flare-up? Learning how to lower your risk of a flare-up or an exacerbation and treating them when they do occur is a big part of managing your COPD. It's important that you work with your healthcare team to create a COPD action plan. Again, another busy slide. You can treat many flare-ups at home, especially if caught early. Your provider will help you devise an action plan in anticipation of this exacerbation. So what is the so-called COPD action plan? Maybe you've heard of it before, but maybe not. A COPD action plan is a personalized plan that you create with the help of your doctor or your nurse practitioner or maybe a COPD care team. And although this is a bit of a busy slide, I just wanted to show you an example of what an action plan proposed by the Canadian Thoracic Society and the Canadian Lung Association looks like. You can use a plan like this one to record what normal feels like for you so that you can tell when you're experiencing a flare-up. You can record the medications you take every day to stay well or your controller therapy, preventative therapy, as well as what you would typically take if you start developing a flare-up or when things start to get worse. By preventing your flare-up from getting worse, you are more likely to avoid an unnecessary visit to the emergency room. Action plans are typically divided into 3 sections. We have the green section, the yellow section, and the red section. The green section is where you record what's normal for you. The yellow section will list signs of your bad day experience that could indicate a flare-up and what you should do when this occurs. And finally, the red section will help you identify when you need urgent medical attention. For example, if you're in the yellow section, your provider may prescribe a fast-acting or rescue inhaler for you to use when you have a flare-up. This will relax and expand your airways to make it easier for you to breathe. And in someone who is on home oxygen, as an example, they may need to dial up how much they take. In addition, they may need to reach out to their care provider to start an antibiotic or steroids. The rescue inhalers, such as Ventolin or salbutamol in this case, are examples of short-acting medications. You may also use a long-acting inhaler every day, even if you feel well, to prevent these exacerbations and control your COPD. Your provider may need to adjust your inhalers to make it as easy and effective for you as possible. And literature suggests that the fewer inhalers you use and the fewer doses required, the better the compliance, which improves your health outcomes. That being said, sometimes there's an added cost to these simplified regimens. Ultimately, the medications chosen for you will depend on the severity of your COPD and the risk you might have of having an exacerbation. No 2 COPD patients are exactly alike. I've learned that. As an example, some patients with COPD have never had a flare-up or an exacerbation, and these patients are often only on one type of long-acting bronchodilator inhaler, in addition to their short-acting Ventolin or salbutamol in that case. Patients who have had even one exacerbation may be encouraged to use 2 combined bronchodilator medications, those LABAs and LAMAs, and they are both long-acting controller medications. They also should always have access to that short-acting rescue inhaler just in case. During an exacerbation, patients may also need to take, as I mentioned, steroids for a few days to help them quickly resolve the swelling in their airways. Corticosteroids, such as prednisone, slow and stop the immune response that is causing your airways to swell. And finally, your provider may prescribe antibiotics for you to take if you suspect the flare-up is being caused by a chest infection. Sometimes patients grow really frustrated when they develop exacerbations and ask themselves, what am I doing wrong? I'm following my plan. Why am I always getting so sick? One potentially contributing factor is the use of one's inhaler. Not all inhalers work the same way, and the devices are variable. Sometimes they're hard to hold, sometimes they're challenging to prime, and it is easy to forget the steps if not shown how to use them properly. In the fast pace of your family doctor's office, it is unfortunate, but likely that in some cases, we may not always do the best job or even take the time to show you how to use your new inhaler. One resource that I've come to really love is this website, lung.ca, hopefully pretty easy to remember if you have access to the internet or a family member that could help you out. I do find this quite useful. Here you will find a drop-down menu on the left-hand side, and there's a remarkable amount of information about various lung diseases and how to keep your lungs healthy. In addition, this website features a user-friendly tool to help you learn how best to use your inhaler. On the top left-hand corner, you'll see here, you'll find that drop-down menu under Lung Health. Further down that list, you will find a button that says How to Use Your Inhaler. As new products come to the market, this website has been very helpful to me when I'm learning about how to use these inhalers, because I, believe it or not, have not used many of them or ever used them, but I still need to know how to teach you how to use them. So I've turned to this website where you can watch videos, read instructions from your own home, and if you have further questions or concerns, you can always come back to talk to us as your primary care provider, or even ask a pharmacist about how to use your device. It's like going to a talk like this. You'll walk away and remember 10% of what you were told, so you may as well have an access to something at home that you can refer back to. All right. Unfortunately, sometimes, even when we use our devices perfectly and follow our action plan to a T, including the steroids and antibiotics and visiting your doctor, your symptoms may not improve. If your flare-up is more serious, if you experience frequent flare-ups, or even if you have other conditions that affect your health, you may have to visit your doctor more frequently or even go to the hospital. Among Canadians over 65, COPD, as I mentioned, is the third leading cause of hospital admissions. We see this all the time. Common signs of deterioration requiring more urgent hospital care includes unresolving shortness of breath, increased need for supplementary oxygen, even nervousness and confusion or drowsiness, and sometimes even chest pain. If this happens, please don't hesitate to call for help or 911. So let's now review the management of COPD in a broader sense. And what I mean by that is outside of the use of medicine. One of the main goals of treatment of COPD is to prevent these exacerbations from occurring in the first place. There are many things that you can do to help manage your COPD and reduce the risk of flare-ups. If you are here tonight because you have COPD or know someone with COPD, I applaud you. You're tackling one of the most important steps in the management of this disease, and that's learning about the disease. It's important to learn what triggers your COPD and what is normal for you, and record this as part of your COPD action plan. By identifying risk factors, you can mitigate them. Smoking is one of the main causes of COPD. Smoking can cause these flare-ups, and over the longer term can cause your COPD to progress faster because of the ongoing damage in the lungs. It's important to consider your vaccination status as well. Because respiratory infections are a major cause of COPD flare-ups, it's important that you stay up to date on your vaccinations for flu, COVID, pneumonia, respiratory syncytial virus, or as we commonly know, RSV. We have discussed a few of the medications used to treat COPD and COPD flare-ups, but what I really want you to remember tonight is that the medication management of this disease process is individualized to you based on your own risk factors, your disease severity, and your inhaler compliance, or how well you use your inhalers. Your doctor, nurse practitioner, and care providers will work with you to find the right device, and sometimes you'll be asked to change devices and try a new dose to optimize your treatment, and this might happen more than once. We're trying to get it right. Non-pharmacotherapy, big term. This is things outside of medicine. These approaches encompass things like staying active, eating healthily. Exercise is a very important part of COPD management. It helps your muscles work more efficiently and makes your lungs stronger. It can help you maintain a healthy weight and give you more energy as well. Healthy eating, as an example, not only helps prevent obesity, but it also provides your body with the energy it needs to support a healthy immune system for when you get sick. Certain foods often have anti-inflammatory properties. And in the later stages of COPD, when weight loss is common, it's even more important that your body receives the nutrition it needs to prevent additional comorbidities or frailty. Back to my friendly GOLD guidelines that we as care providers refer to often. As previously identified in a review of causes of COPD, we probably all know that smoking cessation is a must in preventing COPD. The GOLD guidelines, they report this as level A evidence. It doesn't get better than this. This is the low-bearing fruit, and in my position, this is the don't miss the opportunity to make a difference at every encounter. So if I harass you about smoking cessation, it's because I've been told to, and it makes a difference. Other risk mitigation might include avoidance of exposure with proper personal protective equipment or PPE in the workplace, avoidance of allergens, or even installation of effective ventilation systems, for example, in your home. All right. Your healthcare provider should take the opportunity as often as possible to support you in your smoking cessation journey. We as providers are encouraged to use the 5 A's to help you quit, but you must show some desire and even an initiative to get there as well. We'll try to ask, advise, assess your desire, and assist you in connecting with resources that will aid you in your efforts. And then we will try to arrange follow-up with you to see how things are going, to offer you prescriptions to help, or even to encourage you along and ultimately keep you accountable. There are medicines that can help you with smoking cessation, and I'd be happy to help you navigate that. All right, back to GOLD guidelines again. Here we are talking about vaccinations and why they're so important. We are encouraged as healthcare providers to educate and offer you vaccinations to limit your risk of infection. I'm going to draw your attention to the Center for Disease Control recommendations here for RSV, or respiratory syncytial virus. They've suggested that those over the age of 60 and with pre-existing chronic heart or lung disease, we should be offering this vaccine to. But as you can see here, there is supportive evidence for other vaccines as well, including COVID, influenza, pneumonia, and even the Tdap vaccine, which protects against pertussis, or the whooping cough. Unfortunately, drug coverage does come in here, and although our Ontario coverage does offer some of these vaccines, it's not covering all at this very moment in time. Hopefully soon. All right. Chronic inflammation in COPD can result in immune dysfunction. That's what protects us from infection. So it makes you more prone and susceptible to infections, and especially respiratory infections. Exercise training, and just exercise in general, is an integral part of something that we call pulmonary rehabilitation. And it's actually shown to enhance our immune function and keep us well. The 2023 GOLD report, those GOLD guidelines I lean on heavily, they highlight that this is, again, grade A evidence, or really good evidence and support for pulmonary rehabilitation or exercise. Rehabilitation is indicated in all patients, but specifically in all patients with COPD and high risk for exacerbations. They've been shown to improve shortness of breath, health status, and even exercise tolerance, and it reduces hospitalization among patients who have had a recent exacerbation. Pulmonary rehabilitation leads to a reduction as well of anxiety and depression. Why not? All right, I'm almost done. I'd like now to introduce you to a few of my colleagues who work hard to support my patients and their families with COPD. Both Sherry and Joe work for the Cottage Country Family Health Team in South Muskoka. Joe and Sherry are here to share with you a little about the programs offered through the Cottage Country Family Health Team, including our smoking cessation program, as well as our pulmonary rehabilitation program. So I'm going to let them take it away. First, we've got Joe.
Thanks, Dr. Nairn. So I'm Joanne. You're not coming out.
Sherry.
So I'm Joanne. I'm a registered nurse with Cottage Country Family Health Team. So we have a small talk about our family health team. We have 3 offices, comprised of 2 offices in Bracebridge and 1 in Gravenhurst. I happen to work mostly out of the office in Gravenhurst, although that's changing recently a little bit. Sherry kind of works
At all 3.
all 3.
I'm the
Yeah.
pharmacist with the team.
Yeah.
We're both respiratory educators.
Yeah.
I've been involved with the COPD program since 2009.
Yeah. So, just a little bit about our pulmonary rehab program. We run a couple of different ways. We do in-person groups, and we also run sort of individual sessions on a case-by-case basis for individuals with COPD. A little bit about group and how we run the education portion. We run the education based on a model called Living Well with COPD. It is a model that's been studied, and the studies showed that patients who do the education portion work with their primary care provider, so their doc or their nurse practitioner, but who also work alongside of an educator like Sherry or I, have really good outcomes. And so some of those outcomes would be, decreased ER visits, unnecessary ER visits, decreased hospitalizations, which is really what we want to happen. The big action plan that Dr. Nairn talked about is something that we really focus on in the program to help give patients some control over their illness, know what to do, know how to identify an illness and how to treat it before it leads to an unnecessary ER visit or hospitalization. So through the education, patients do learn a number of self-management skills that are necessary when you have COPD. They adopt some healthy lifestyle behavior changes, and really the program really gives just that increase, it empowers them to help them control the disease at home without it getting out of control, and also, thereby increasing quality of life. So our group programs we run, we usually run with 2 educators. It'll either be a couple of nurses or a nurse and our pharmacist. We've been currently running since COVID, just a couple of times a year so far because numbers have been a little bit lower. So we're trying to run 1 program a year in Bracebridge. And when we run that session, it's out of the Sportsplex. So we meet twice a week. We do an hour of exercise and an hour of education at each session. And the exercise portion is geared to each individual. So it's not a competition, it's not a marathon. We're not trying to exercise ourselves to the point of exhaustion, and each individual is different. So we help individualize the exercise as well. So for group, we really like to see people in the more mild to moderate stage. So people who we can help get a little more active and get moving a little bit more. Just as a side note, so we work for Cottage Country Family Health Team. Algonquin Family Health Team up in Huntsville also runs the program. And I think they run out of the Healthy Living Center up in Huntsville, just as a side note. We have, so the 8 weeks, it's twice a week for 8 weeks. We have several different speakers. We have, Sherry does a really good farm talk. We've got a respirologist that comes in and talks about the lungs and breathing techniques and oxygen and that type of thing. We've got our registered dietitian and our social worker to talk about diet and decreasing anxiety and that sort of thing with COPD. So we have lots of different speakers, so it's not just listening to sort of us speak for 8 weeks. There's lots to talk about. And of course, to be referred into the program, you do have to have a diagnosis by spirometry. So we make sure that happens. And before you get into group, we need exercise clearance, that sort of thing from your physician. So to get referred into the program, we do require a referral from your family doctor. And we do see patients outside the family health team as well. So we do get referrals from the walk-in clinics and that sort of thing. If you don't have a healthcare provider, you could give us a call. I do have a number here. If anybody wants to talk to us after, I can give you the number for our corporate office that you can give a call to, and they can disseminate messages. If you don't have a family doctor, we can try and work with the team to get you into a program if you've already got COPD, but no family doctor. And like I said, the home-based model we ran during COVID because we had to change our group program into a virtual model. But we don't really run the home-based model now that we're back to running groups. Like I said, for individuals on a case-by-case basis, we can do individual education for people who don't fit the group model or can't participate 100% in group. We could see you in one-on-one. And the virtual models, there's a couple of really good models. Dr. Nairn already touched on one, which is through the Canadian Lung Association. She had the website up there. There's also another really good one through the Lung Health Foundation, and as well through the website Living Well with COPD. There's also a virtual program on there. So lots to learn.
Sorry. I just wanted to say that we're really proud that we have this pulmonary rehab program. Dr. Nairn mentioned how many thousands of patients have COPD in Canada. Only 5% of COPD patients in Ontario have access to a program like ours, so we're really proud of it. We've been running it for about 15 years. Put that little plug in. So I'm the pharmacist with the team. I've been involved since 2009 with COPD, and my focus, I've been running the program with Joanne, the 8-week program at my focus at the beginning when we first meet with patients, we do pre-assessments, is to get them using their inhalers properly. And I'm not exaggerating when I say 95% of patients don't use their inhalers properly. Dr. Nairn talked about that too. Either they're not using the devices properly, or they're not using them all the time like they should be, or they're not using them at all. So we can make a difference right away, getting people using their devices properly. Some people it's just a little bit of things we have to kind of tweak, but sometimes it's really significant issues with the way they're using their devices. We want to make sure they're being compliant, using them the way they should, the maintenance inhalers every day or twice a day, and knowing the difference between the rescue inhalers, that fast-acting Ventolin, and the ones that they need to take every day to keep those airways open. If we can get the people using inhalers properly, using them the way they should be, we can make a big difference in their level of shortness of breath, reduce lung infections, improve their quality of life. So, the inhalers are so important, and that's why my focus is on that. I also want to look to see whether the patient's using the right device. They come in dry powder form, they come in mists. Some people don't have a strong enough draw to draw the powder inhalers in. So I work with their physicians and their nurse practitioners to get them on the right inhalers. As Dr. Nairn said, there's been so much research and development in those inhalers over the last few years. It's confusing sometimes for the physicians to keep up with all the new devices, so we're here to help them with that. We want to make sure they're on the right combination, the right meds in the inhalers based on their severity. Dr. Nairn talked about that. The other thing that's important is that a lot of people don't realize that some of the things they're taking over the counter can affect their breathing. Some of the antihistamines, decongestants can affect the mucus in the lungs. Some of our prescription drugs can affect the breathing, so I'm always looking at that as well. Dr. Nairn already talked about the vaccines, so I don't have to talk about that. All right. Now smoking. Oh, it's already up here. Okay. All right, so we run a smoking cessation program. We've been doing that probably for about 15 years as well. We have nurses, some trained in smoking cessation counseling, myself as well. I'm not sure if any of you are smokers or ex-smokers. Quitting smoking is probably one of the hardest things that someone has to go through. It's one of the hardest addictions to overcome. I've seen patients that have been alcoholics and cocaine addicts, and they find quitting smoking harder than getting off those other vices. We can help our patients with supporting them not only with counseling to help them make it easier to get through the process of quitting smoking, but also providing free nicotine patches, gum, lozenges. I used to work in community pharmacy in the past, and I'd see people running in on New Year's Eve buying nicotine patches. No plan, really. They're not really prepared. And they usually fail. They're usually buying the wrong strength of the patches, and they're not buying, the fast acting for breakthrough cravings. So we can really get them on the right products to make them more successful. A lot of people, Dr. Nairn mentioned, you do have to be motivated to quit. But even if patients aren't, they can always contact us, and we can talk about our program and explain how we can help them make it easier to quit. And let's see if there's anything else I missed. Yeah, I guess the important thing is that with our smoking cessation program, we work together with the patient to make it easier, prepare them for any setbacks or how to deal with setbacks, social settings, avoiding people that smoke, etc., just to make it easier. And I think that's everything. Did I cover everything on there? Okay. All right, we do see family health team patients, but we also see patients that aren't with our family health team. Have to be referred with your primary care provider. Thank you.
Awesome. Thank you so much, Sherry and Joanne, for coming tonight and just offering a little bit of advice on what your programs offer. So I have one sort of conclusion slide, and that's just to carry on the theme of the smoking cessation goals. And I hope that if anyone is struggling, they realize there are resources out there to help you. If not through the family health team, South Muskoka District Health Unit also has an abundance of resources available to you. So I urge you to check it out online through the District Health Unit, where else you can get help. I'm really excited that you came to listen tonight, and hopefully you took something away from this evening and share with your friends and family and loved ones tidbits that you learned tonight. Thanks again for coming.